I'm Melissa Danko, as Dr. Jackson said, and I have nothing to disclose. So we're going to focus the next 15 minutes on the esophagus. So just in a quick review, since a lot of you probably haven't seen children in a while in your office, esophageal atresia is the most common congenital anomaly of the esophagus, but the other things we deal with as pediatric surgeons are severe caustic injuries to the esophagus, as well as congenital and sometimes very recalcitrant acquired strictures. We see achalasia, and then much more rarely esophageal masses and tumors. So just to review, back to your medical school days, esophageal atresia occurs approximately in 1 in 3,000 live births. There are numerous associated anomalies seen in as many as 50 to 75% of patients, which really can add to the complexity of their care. And the prognosis has significantly improved over the last couple of decades. And now the survival is approaching about 90 to 95% in the literature. And this is just a laundry list of all the associated congenital anomalies that can occur with these patients, the most commonly being cardiovascular and genitourinary. The type of esophageal atresia that we see the most commonly is this one in the middle, type C, with the proximal blind ending pouch and the distal tracheoesophageal fistula. The other one that most of the studies we're going to talk about today refers to is this long gap, or pure esophageal atresia, where there is no fistula, just a blind-ending proximal pouch, and then a distal blind-ending stump that hopefully you hope is in the thoracic cavity, but sometimes can be in the abdominal cavity. And the way we repair this, just to review it very quickly, we take the distal tracheoesophageal fistula off the trachea, repair the trachea, and then sew those two ends together. Most of us do a single layer anastomosis. And that's what it looks like in situ. And the other topic that we're going to quickly include today is esophageal injuries. This is a dreaded film that we all do not like to see in the emergency department at 2 o'clock in the morning. But button batteries and ingestions can cause significant damage to children's esophagus in as quickly as a couple minutes of exposure. This is a picture of a devastating long stricture that was the result of an ingestion. And then on the right, you see sort of a protocolized approach to what to do for ingestions. A lot of times these end up with significant strictures, and if you can't get this to resolve, you often have to talk about esophageal replacement procedures. This is way too much to cover today in the brief amount of time we have, but when we talk about replacing the esophagus, we have to figure out a conduit that works. Most of the literature talks about either using the colon or pulling up the stomach, although there are a couple of case reports on some groups that are starting to use the jejunum. But this is too much to cover today, but we're going to talk about, or very important to keep in mind because these patients have a lot of morbidity as they approach their adult years. So focusing on the things that our adult colleagues are going to see, the complications, these patients have a lot of morbidity that lasts them lifelong. These are more common in patients that start off with long gap esophageal atresia, and then more common in patients that have the severe associated anomalies, extremely low birth weight, as well as the cardiac defects. And this picture just shows us all the different factors that go into thinking about and taking care of these patients, as well as it brings attention to the significant morbidity they have with GI morbidity as well as respiratory problems. The early complications, which are what you guys may not see so much of, but become a little bit more significant as time goes on, usually seen in infancy or childhood, fairly common, and they're usually related to the anastomosis. So strictures, leaks, dehiscences, and recurrent tracheoesophageal fistulas. Esophageal stricture is what we deal with most frequently. It is a very common early sequelae. It is reported almost 80% in the literature sometimes. And it's much more common in patients with long gap esophageal atresia because of the tension that's put on the anastomosis. But this affects adult patients as well, which I will get to. Recurrent tracheoesophageal fistula is something that we see, but occasionally there are a couple case reports of it presenting in adults. Late presentation is patients that are having recurrent pneumonias, pulmonary infections that you just can't sort out. Once it's diagnosed, though, endoscopic treatment is an option. We basically coagulate the mucosal lining of the fistula and then inject some fibrin glue. If that fails, unfortunately, they need a larger operation to fix it. The late complications are really what are going to affect these patients as they become adults. And you see a list of some of the topics that we're going to discuss. The majority of patients with repaired esophageal atresia do end up having reported symptoms into adulthood. These include things like dysphagia, regurgitation, heartburn, and aspiration. But despite this, there are a couple studies that show that their quality of life is pretty good. So dysphagia is one of the most common things that we will hear about and you will hear about in these adult patients. It seems to be worse in patients that have esophageal replacement. And approximately up to a third of patients have reported trouble swallowing solid foods, and almost half need to have fluid or liquid with their meal. Esophageal motility is also one of the GI morbidities that we hear about a lot. Almost all patients have abnormal peristaltic activity when this is investigated, and the cause is a little bit unclear. Some people postulate that this may be due to the intrinsic congenital defect. There have been some animal models that have shown that both the intrinsic and extrinsic innervation of the esophagus is changed in patients with esophageal atresia, and this has actually been confirmed with histologic samples from patients with repaired esophageal atresia. The most common thing we think is that the operative repair has disrupted the innervation of the esophagus, as we often have to mobilize both the proximal pouch and the distal esophagus quite extensively to get the two ends together. The other thing we see is that not only is the esophagus motility affected, but the gastric motility is also affected. Delayed gastric emptying as well as altered gastric peristalsis is very common in these patients. Manometry is where we get all of this data from. When we do manometric studies of adults that had repaired esophageal atresia, they show non-propagating peristalsis throughout the esophagus in total, as well as ineffective distal wave amplitudes of the esophageal body. Interestingly, though, the pressures and the lengths of the upper esophageal stricture as well as the lower esophageal stricture seem to be similar to healthy, normal patients. So gastroesophageal reflux is one of the things you'll hear about most frequently in these patients as adults. We tend to try to do anything to preserve the native esophagus, and this really promotes gastroesophageal reflux in these patients. They have a shortened intra-abdominal length of esophagus, as well as the motor function that we've discussed, whether it be acquired or intrinsic. Symptoms are the same as regular population with gastroesophageal reflux: regurgitation, heartburn, reactive airway disease, and aspiration pneumonias. And in the literature, the prevalence of GERD in patients with esophageal atresia is anywhere from 20 to 75%. The group out of Finland has done extensive research in this, and in their experience, they saw 45 to 50% of adult patients that had esophageal repair have GERD up to 10 years after their primary repair. This was based on both pathologic pH monitoring that they performed as well as histologic examination of the esophagus. They did a study on kids. They basically scope everybody at a year out and then again when they're 15 years old, and then some intermittently. So they said that most children with pathologic GERD develop histologic esophagitis or have anti-reflux operation by the age of 5. And interestingly, they found that those patients, that they did not diagnose any new cases after the age of 5. And their concern and what they've noticed and observed is that once this pathologic GERD or esophagitis is detected, it rarely resolves. So esophagitis, we know, results from pathologic GERD, and based on the literature, it's demonstrated in about 25 to 75% of adults with repaired esophageal atresia, which brings up the question to wrap or not to wrap. This is usually a childhood question. We don't tend to recommend wrapping adults with persistent reflux. Most people would do a Nissen, or we sometimes talk about the floppy Nissen in children. There are a lot of groups that believe in doing an anterior partial wrap versus a callus Nissen to lengthen the intra-abdominal length of esophagus. These procedures are not to be undertaken lightly. They have high morbidity. They often require redo operations or more than one operation. And then, unfortunately, there's also a high recurrence rate of reflux even after they have the anti-reflux procedure performed. Esophageal strictures we talked about are kind of an early presentation, but we can also see them late. Surprisingly, they have an 8 to 17% prevalence in adults. They are more common in stage repair or endoside anastomosis or sleeve anastomosis. And then recalcitrant strictures are usually associated with reflux. So one of the things we've noticed more recently in the literature is this idea of metaplasia. Gastric metaplasia arises secondary to reflux-induced mucosal injury. It is a pathologic condition. The squamous cells change over to columnar epithelium. Unfortunately, it is often already present in childhood after primary esophageal repair, and the incidence increases with age. There were 2 studies that combined looked at 123 adult patients, young adults, with the mean age of 16 years, and they found gastric metaplasia had already developed in 13% of these patients. Another study in Finland performed in 101 adults, tried to see who was most at risk for the development of this. And they really part out that anybody with an esophageal stricture requiring resection in childhood, recurrent tracheoesophageal fistula, age greater than 30, and long gap esophageal atresia seem to be most highly associated with columnar metaplasia, which brings us to the concern for Barrett's. There have been a couple studies more recently that have shown that the incidence of Barrett's esophagus is 4-fold higher, 7% in repaired esophageal atresia than the normal population. And a study out of Australia showed that 7 out of 62 adult patients with repaired esophageal atresia already had Barrett's esophagus on endoscopy. And this is a nice summary slide of a lot of the work that's been done showing the different percentages of symptomatic reflux, esophagitis, all the things we've talked about, and Barrett's esophagus. What's not included is a more recent study that was published last year of 120 patients that showed about 70% of them had histologic evidence of esophagitis, and 50 out of that 120 had gastric metaplasia with 1 showing Barrett's. So one of the more innovative studies that I looked at is a social media survey. So there's a group of pediatric surgeons out of Wisconsin that made a 50-point survey that they then published and presented to patients and parents that are in online communities for support groups for esophageal atresia. They had this for 2 months, and they got 445 patients responding. You can see the mean age is a childhood age. That's clearly the parents that are filling it out for the children. But more than half of them reported dysphagia, with a lot not experiencing any resolution. And about half of the patients between the ages of 10 and 50, and 35% of patients greater than 50 years old had continued dysphagia. You'll see 3/4 reported symptoms of reflux, with about 1/4 of this undergoing anti-reflux surgery. And as we've discussed, about 1/4 of those needed more than 1 anti-reflux procedure, and almost 1/3 reported recurrent reflux despite intervention. This just shows all the complications of the patients that reported reflux, pneumonia, asthma, esophagitis, all the things we talked about. Obviously, this study has limitations. It's self-reported by the patients, so we have no way to verify the validity of what they said or report. And then it's also subject to selection bias, as they were part of an online community for esophageal atresia. So the big thing that's come to light in all of the discussion of metaplasia makes us very concerned for these patients' risk of cancer. To date, there's 8 cases reported, 5 squamous and 3 adenocarcinomas. All of these patients had esophageal atresia with distal tracheoesophageal fistula, so the most common type of congenital anomaly that we see. And the patients were young. 7 to 8 out of 8 of them had a history of stricture, and unfortunately, none of them had any other risk factors. So it is very concerning. They had an aggressive, much more aggressive course, and were diagnosed at younger ages. Interestingly, though, another population-based study showed, with a mean follow-up of 35 years, that they did not have any cancer cases. So this is one of sort of the hot topics right now in this literature, which brings up the idea of surveillance. There's likely to be more cases of metaplasia, more cases of cancer, as more of these patients are surviving. Surveillance under endoscopy, groups are very much advocating that you biopsy the whole distal esophagus, the entire anastomosis, and then anything else that looks abnormal. There's 2 studies that make recommendations right now, and they seem to make different recommendations, so it'll be interesting to see what we come up with in the future. A multi-center study out of Europe basically says that they should all be scoped before they transition to adults. If there's no Barrett's seen, you should repeat their endoscopy every 5 to 10 years, but if you see Barrett's, they need a repeat endoscopy every 3 years. The group out of Finland makes a little bit more aggressive recommendations with scopes every year if they see Barrett's. I'm just touching very quickly on some other things besides gastrointestinal dysfunction is impaired respiratory function in these patients. There's a study out of Sweden that basically did pulmonary function tests on 28 patients with repaired esophageal atresia, and 22 of these had a history of respiratory symptoms, and they discovered abnormal peripheral airway function in 61%. Interestingly enough, their symptoms and whether they had disease did not correlate. There was only 1 patient that had no reported symptoms and no reported findings. But this emphasizes the importance of pulmonary follow-up as well. Musculoskeletal deformities are also fairly significant in this population, but we think it's due to the fact that a lot of them were repaired with non-muscle-sparing thoracotomies. This incidence should decrease over the next couple years as we've switched over to muscle-sparing thoracotomy as well as thoracoscopic repair for esophageal atresia. And then just to touch on their health-related quality of life, there is an abundance of literature coming out about this. And they suggest that patients with esophageal atresia have a reduced health-related quality of life. Interestingly enough, though, the associated effects seems to be less than expected when taking into account all the high morbidity that we've discussed. But the existing studies are limited by small populations, as well as there's no condition-specific questionnaire yet for these patients. So that'll be interesting to see what comes in the future. So in summary, esophageal atresia predisposes the patient to severe reflux, as well as pulmonary issues. Long-term follow-up is required even in asymptomatic patients, and then more studies are needed on a large young adult and adult patient with esophageal atresia to develop effective transition of care and surveillance recommendations. Thank you.